So I trained as a neurologist and a psychiatrist in the combined program at Brown, and then from there did a research fellowship to try and look at combined treatments for patients with seizures. And in doing so, from there we did research trying to develop treatments for patients with non-epileptic seizures, what used to be referred to as pseudo-seizures, not referred to as pseudo-seizures anymore because it's a pejorative, kind of derogatory reference. But non-epileptic seizures look just like epilepsy, but there's no epileptiform discharges, no abnormal brain cell firing associated with those seizures. So because non-epileptic seizures aren't treated by anti-epileptic drugs like epilepsy is, we needed to develop an intervention or a treatment to help those patients. So what we've done over the past decade has been to develop non-pharmacologic interventions. So working with psychotherapies, we've been able to help patients reduce their seizures, reduce their comorbid symptoms such as depression and anxiety, and also to improve quality of life and functioning. That model that we used was actually originally derived from an intervention that was used for patients with epilepsy. So now we've got data both on patients with epileptic seizures and non-epileptic seizures where there is a reduction in seizures using this intervention. That's important because we've made a false dichotomy separating out neurology and psychiatry, separating out the brain and the mind. What this approach is, in some ways it's a renaissance of bringing the brain and the mind back together. So looking at brain and behavior mechanisms, that's a neuropsychiatric approach. And that not only applies to seizures, that applies to many other neurological and psychiatric disorders. So for instance, in dementia, where you have behavioral manifestations in dementia, that's core neuropsychiatry also. And where that's relevant is the treatments that we've developed for patients with seizures. We're also able, because many of those patients with seizures have histories of traumatic brain injury, there are cognitive effects that they experience. We've found in some of the treatment trials that we've done that the patient's seizures not only improved, but also they reported a qualitative improvement in their cognitive complaints. So we're applying actually this treatment now. We're looking at helping patients with mild traumatic brain injury who continue to have symptoms. So when we take patients, we want to, in our treatment trials, we want to make sure that the results will be generalizable. And so we actually have a pretty open inclusion and limited exclusion criteria. And the reason why we do that is because we want the people who enroll, we want people who aren't enrolled to have results that might be able to be, that have external validity. And so many of the patients who come to us, they've had a history of traumatic brain injury. Many of them have had a history of some type of a comorbidity like depression, anxiety, post-traumatic stress disorder, some history of trauma or abuse that occurs very commonly. So we don't exclude those intentionally for generalizability. So it's two different things. For patients with epilepsy, only about 60% of seizures are treated with anti-epileptic drugs. That leaves a significant number who don't have their seizures controlled in the epileptic population or the patients with epilepsy. Epileptic seizures can also be addressed with surgeries. But again, it's not 100% seizure control rate. So one of the reasons why this intervention was developed, it was originally developed by the Andrews Ryder organization, and they used it initially for patients with partial complex epilepsy or focal seizures. And the approach was helping patients to identify their aura and then to see what their triggers are for seizures, and developing some behavioral techniques, they were actually able to reduce epileptic seizures. What we did is we've modified that approach, integrating other elements that are important in patients with non-epileptic seizures, And in doing so, that now allows patients with epileptic or with non-epileptic seizures to be able to be treated with this approach. So it's interesting because for epilepsy, when many years ago there were mainly 3 or 4 basic drugs that were used, and that's what was available. In the 90s, there was significant growth in the number of anti-epileptic drugs that were made available. There continue to be some releases and developments. And then over time, the use of surgery, again, has become more validated and has reduced seizures in a select number of patients. And then a third type of modality or intervention are neuromodulation procedures, and that's things like vagal nerve stimulation, deep brain stimulation, neuropace, response systems. So those are all pharmacologic or electrical or surgical approaches. The approach that we've been developing, maybe to augment those approaches, it's basically a therapy. It's a psychotherapy that's used to help patients either with epilepsy as it was originally developed or now with non-epileptic seizures. We haven't tested this intervention in children. There is discussion now about conducting a randomized trial in children with non-epileptic seizures, and that's some of the work that's coming out of the non-epileptic seizures task force from the American Epilepsy Society and from the International League Against Epilepsy. It's been a process that's been over time systematically assessing what are the proper assessment tools and then what are also some of the risk factors. And the group that's leading that with Sigita Pliopoulos in Chicago and with Rachel Kaplan at UCLA and Julia Doss in Minnesota, the Epilepsy Foundation funded a multi-center trial to look at risk factors for children with non-epileptic seizures, and that's been written up this year and published in Epilepsia, and then more papers will be coming out. More papers will provide more data to appropriately design the trial that we're talking about, but I don't have a specific timeline on when that trial will occur. Yeah, so I think, as we've talked about before, when we're talking about treating patients with seizures, as you probably know, and I've learned this from one of my distance mentors, is that treating the seizure is not the sum total of treating the patient with epilepsy, and paying attention to the neuropsychiatric comorbidities of epilepsy and of patients with seizures, it may be just as important as the seizure itself. The comorbidities, such as depression, anxiety, PTSD, traumatic brain injury, functioning, medical utilization, all of those are significant in the life of the patient with seizures, either epileptic or non-epileptic seizures. And it's also important to address from a healthcare perspective. So that's one of the main areas of focus that we've wanted to address, is not just the seizure, but the other relevant areas in the patients with seizures' lives.